will now request the pillar behind this event, Dr. Debasis Patra, to inaugurate the next session.
So, good afternoon everyone. The next session is an inauguration session by the Paediatric Rheumatology Society, and usually we do it at a very short basis, just for it will be done by our organizing chairperson. May I request our organizing chairperson, Dr. Priyankar sir, on the stage. Then I would request our beloved president of our society, Dr. Vijay Vishwanathan sir, onto the stage. Then I would request Dr. Vignesh sir, our secretary of our Paediatric Rheumatology Society. Then I would like to request our IAP Odisha State Branch President, Dr. B.K. Bhuiyan sir, followed by IAP Bhubaneswar City Branch, Dr. Ashutosh Mahapatra sir, followed by Central IAP EB members, Dr. Seba Ranjan Biswal sir and Dr. Sunil Kumar Aglawal sir. I would like to pass on the mic to our chairperson, Dr. Priyankar sir, to officially inaugurate the conference. Before that, I would, before starting the session, I would like to play a video, a short video from our IAP president, Dr. Basavaraj sir. Kindly play the video.
Namaskar. Greetings from Indian Academy of Pediatrics. On behalf of 48,000 members, let me congratulate our IAP Rheumatology chapter for organizing a 22nd Pediatric Rheumatology National Conference on Rheumatology at Holy City of India, that is Bhubaneswar, led by none other than Dr. Vijay Vishwanathan, who is the chairperson of our IAP Rheumatology chapter, Dr. Vignesh, and Dr. Priyankar Paul. Because of their effort, and our young chap who has been working in the field of pediatric rheumatology, I know him personally, Debasis Patra for organizing this conference. Under the guidance of stalwarts of our IAP Odisha, led by Dr. Mamta Devi, Dr. Ashutosh Mahapatra, Dr. Murtyunjay Das, who has been helping, and Dr. Bhuyan, Dr. Prashant Sabot, and many of the people who have been very instrumental in guiding, with the always the support of people like Dr. Shushruth Das, who are working behind the scene to help these conferences and more successful. And rheumatology is one of the most upcoming specialty, especially following the COVID-19. A lot of newer things has been emerged in the field of pediatric rheumatology, which has been well recognized across the India within international faculties like dept and many other faculties who has been taking part in today's deliberation. I am sure whatever the interaction and deliberation which is being taking place, it is going to be very, very useful for the practicing pediatrician. Best wishes for this conference. I am sure the deliberation will make a big difference in the care of any children. Thank you once again, team Odisha and Bhubaneswar City branch, which is doing a wonderful work in coordination with all the subspecialties as well as the state chapter for bringing the more academics to the Bhubaneswar. Best wishes for this. Thank you very much.
Thank you, Basavaraj sir. And I pass on the mic to our organizing chairperson, Dr. Priyankar Pal sir, to carry forward the inauguration of the session.
Thank you, Debasis. So I announce the conference officially open. So we have been having the conference since yesterday evening, but now I think we have the official opening.
And we'll proceed with the lighting of the lamp. To call upon the stage our organizing co-chairperson, Dr. Mamta Devi Mohanty ma'am, and also our senior Dr. Leena ma'am, Dr. Mrityunjay sir, Dr. Arthabandhu sir, onto the stage.
सर्वकार्येषु सर्वदा ॐ तत्सत्। 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 ॐ तत्सत् are standing behind the core workers, behind the success. Doctor, all are standing there. Please come forward, Kanu and our Siddhan Swarup and Chandra, Abhinas, Vikrant, where are you? You are not visible. Please come forward. Please come forward. You are the persons who brought the success to the conference. Where is Nitish, Pratik Dev? Please come forward, all of you.
Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganapati Bappa Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Ganapati Bappa Moraya Om Ganapataye Namo Namah Shri Siddhi Vinayak Namo Namah Ashtavinayak Namo Namah Mangalamurti Moraya
So now the formal inauguration of the oration by Vijay sir, Vignesh sir.
Was a fellow Cancerian born on 7th of July 1933. An alumnus from Madras Medical College, went on to proceed to his residency in Children's Hospital of Philadelphia. And since then it's been a journey, an enviable journey. He went to obtain his certification in Paediatric Rheumatology in 1992. 1996 he became the Professor of Pediatrics at Thomas Jefferson University, later Professor Emeritus. He was in the Board of Directors of American Juvenile Arthritis Association, American Board of Pediatrics. He has several awards, including the Outstanding Teacher of the Year Award, Children's Hospital of Philadelphia, Dean's Award for Teaching Excellence, Thomas Jefferson University. In 2000, he became one of the 2 Indians to become the Master of American College of Rheumatology. He also was honored with the James Cassidy Award for Teaching Excellence by College of Rheumatology. He then served as a member of Sub-Board Examination Committee for Paediatric Rheumatology, American Board of Pediatrics from 1990 to 96. He's got lots of publications and accolades, and he has authored 5 books The most interesting being thinking skills for the digital generation and explaining Vedic religion to the digital generation. It's my honor to have Dr. Dirk Foel for this prestigious oration today, and I call upon Dr. Vignesh to introduce our esteemed speaker.
Good afternoon, one and all. So it's my pleasure to welcome you all for this 9th Professor Balu H Athreya Oration in Paediatric Rheumatology. So for today we have Professor Dirk Foel, who is a professor and head of Paediatric Rheumatology and Immunology, who is a full professor in the University of Munster, Germany, and he is the head of the Department of Paediatric Rheumatology and Immunology. His research focus is on clinical transmission science. On one hand, his laboratory works on the mechanisms of innate immune dysfunction and immunoregulation. On the other hand, his group aims for better strategies for individualized anti-inflammatory therapies. The overall objective is to translate the knowledge from the basic science on innate immunity into diagnostic tools to improve the stratification of patients with regard to their disease characteristics and prognostic. So Professor Foel coordinates major national and international research consortia and have an active role in the international networks such as EULAR, Printro, or Press. His department is a member of the European Network for Rare Diseases, ERM-RITA, and also member of EULAR Center of Excellence in Rheumatology Research at the University of Munster. Patient care, research and teaching are inextricably linked in this department. Both clinically and scientifically, the main work is on diseases with rheumatic diseases, infectious diseases, immunodeficiencies, autoinflammatory syndromes, and chronic inflammatory bowel disease. In this research group working on immune dysregulation, they work both in human as well as murine system. So Professor Foel is the current national coordinator for Paediatric Rheumatology International Trials Organization. He is a chair, Lowy Foundation for Paediatric Rheumatology Research. He is a member, vice chair, board of the ethical committee at the University of Munster. He is the member, EULAR Council chair of the EULAR Paediatric Rheumatology Committee. He has several awards and honors to his name, notably the Europe Asper Award for Inflammatory Bowel Disease Research in 2018. And there are numerous research achievements and activities, such as the study physician for the National Multicenter ICSI follow-up study in 2001. And he's a principal investigator and coordinator of 2 large government-funded registries and biometrical banks in pediatric rheumatology. He is the present head of the Munster Reference Center for Autoinflammatory Diseases, and he also served as a coordinator of the EU FP7 project, Miami, MIAMI. He is also the World Package Lead of the EU Consortium, the Immunome Project in Autoinflammatory Diseases. He has around 240 peer-reviewed journal publications, 25 peer-reviewed reviews, 6 book chapters, and more than 17,700 citations with H index of 65. So with this introduction, it's my proud and privilege to introduce Professor Foel to you for his oration. Professor Foel, please.
Thank you very much for this very, very kind introduction. So nice words. Thank you for that. And thank you for the invitation. It is really a pleasure to be here and an honor to give this oration. I have do I have to do anything to show this? Okay. I have a disclaimer at the beginning. I have to admit that I never really have spoken to Balu Athreya personally. I know him, of course, from my first Park City meeting. When I attended that meeting, he already achieved an achievement award at that time, so much more senior, of course. And ever since then, when I visited conferences in the United States and also elsewhere in the world, he was around, and he was a very, very nice person to have around, obviously, an inspiration for so many of us. And with that, one can really say a giant in the field, and it is an honor for me to do this oration in his name, in honor of him. So the title of the presentation is 2024, what is new in Still's disease. It's the disease I'm mostly interested in, and I have some disclosures. So I have actually received research funding from pharma industry. I served as a clinical trial investigator. I also received honorarium. So I skip this. The agenda for this presentation will be as such. So first of all, I want to reintroduce what you already know, so maybe a short introduction to where we stand with our understanding of Still's disease today. Then we already heard about new EULAR and press guidelines for Still's disease. I coined this "What is new?" win part of the presentation. You already have been introduced to it. Maybe I go into a little further detail. And then in the last time it is more on how I treat or how to treat the hot part, so to say. So maybe what we learned from that with regard to treat the target window of opportunity. And the theme of this meeting is from experience to evidence, and also to teach and learn more from each other about treating the target, and I think this fits that. So what to know about Still's disease? One could say there is not much need to talk about it actually, because it's the cornerstone of pediatric rheumatology in a way. It was actually the first description of childhood arthritis that was provided by Sir George Frederick Still in 1897, so really a long time ago. And when he described these first patients, 19 patients, 12 of them we could consider today as patients that probably suffer from a long-standing systemic juvenile idiopathic arthritis or Still's disease. And others did not have systemic features. At that time, actually, of course, it was not known what was the origin of that disease. Later then, not so much later actually, there was the discovery of the concept of autoimmunity, and we were told that it is impossible that our body would turn its immune system towards itself, because this is not compatible with life. The horror autotoxicus that was called by Paul. It took a long while until 1971 until Weilberger's actually described something in adults that mimicked Still's disease, and he called that adult onset Still's disease, to say, listen, there is something in adults that somehow resembles the disease pediatricians know, and they call Still's disease. Then later in 1977, there was the classification scheme that had a part between European and Americans and others. So the diseases were called juvenile rheumatoid arthritis or juvenile chronic arthritis, and later we then had the international EULAR classification system that you all know today, and you all also know that systemic arthritis is one of the subcategories of this disease. And even later than that, the concept of autoinflammation was introduced. Until then, we thought that everything that was juvenile idiopathic arthritis in a way was an autoimmune disease, where SJA was not fitting that well, but with this concept of autoinflammation, and then Kästner, as opposed to horror autotoxicus, coined the terminus horror autoinflammaticus, something new entered the field. But we can summarize that up to then, Still's disease in children was actually the terminus for something that was a subcategory of juvenile idiopathic arthritis, which meant something that has an onset before the age of 16 years, ongoing course, and chronic arthritis for at least 6 weeks. This would have been required to actually classify a patient as SJA if you follow strictly the EULAR classification rule. An arthritis of 6 weeks, a child needs to suffer from with Still's disease until you could really classify it. And I'm always I find it very important to always emphasize that classification criteria are not diagnostic criteria. So there's no need to wait for that, of course, to diagnose a patient. So what do we see then in SJA? You know, it is a disease that comes early in life. It does not have the highest incidence. It is actually a higher incidence you have in India than we have in Europe. Our proportion of SJA in the JA field is lower. There are typically no autoimmune phenomena, at least in the beginning, and we have this three main features. It is the spiking fever that comes at night. It is the rash, the transient rash, sometimes a little itchy, that comes and goes away. It comes especially with fever, especially in the late evening hours. It's the residents' rash because the consultants don't see it in the morning rounds. The residents see it at night, and then nobody believes. And it is the arthritis, of course, that makes it actually, brings it under the umbrella of Still's disease. In George Frederick Still's publication, the patients had severe arthritis and really disabling disease, and we can consider that they really had long-standing arthritis without receiving, and disease without receiving a really anti-inflammatory therapy. Now, in reality, today, we often see this disease in these patients without or before they develop the full arthritis. They may have arthalgia, and in adults, the adult onset Still's disease doesn't require arthritis to be present. So often we only see fever and rash and signs of systemic inflammation in the beginning without arthritis. And then it's difficult to really call that disease systemic juvenile idiopathic arthritis, because when no arthritis is present, how can you call a disease arthritis? What we also know is that the cause and complications are quite diverse. We have traditionally seen this as a disease that can come monocyclic, polycyclic, or persistent. I will come back to that. There's an early complication, but it can also occur later or at any stage of the disease, that is macrophage activation syndrome. And there are the late complications we really today want to eliminate. And this is inflammation related, it's the joint destruction, the growth deficit, and the amyloidosis in different organs, especially the kidneys, of course, but also heart and other organs. And it is the therapy related complications, osteoporosis, we heard about it yesterday, and the growth deficit can also be related to the therapy, not only to inflammation. And the cardiovascular problems we can also have. You see here a child with a growth deficit, and the A in here coins the start of anakinra treatment in this patient. You see that there is a catch-up growth, but the same patient actually with severe articular disease, hip, he needed hip joint replacement and has several damaged joints. So where do we see it now in the spectrum of the different disease, let's say, flavors we can have with inflammation when it comes to pathophysiology? The origin of a disease like this is still unknown, therefore it is idiopathic. If we knew the cause, we wouldn't call it idiopathic anymore, and if anyone finds out the cause, maybe that is worth a Nobel Prize. But what we knew, or what we knew for a long time, is that there is this autoimmune disease type of different rheumatic diseases, and there's more the inflammatory type. And until the discoveries in genetics, we had little clues on what was really going on. But with genetics, we discovered monogenic autoimmune diseases at the very far end of that spectrum, like ALPS or IPEX syndrome or other, let's say, inborn errors of immunity actually that cause immune dysregulation and autoimmunity, clearly by features of adaptive immunity, T cells, B cells, and autoantibody production. And this is what you then can also target. In autoinflammation, we have the overactivation of innate immunity without predominant autoimmune features. It is monocytes, granulocytes, macrophages that are activated, and they secrete a lot of cytokines. And they do a cytokine storm and hyperinflammation, and that is then what makes autoinflammation, and we discovered a lot about that, again, from monogenic diseases, such as FMF, IL-1-driven diseases, and others.
And then there are a lot of diseases in between, and Still's disease is somehow in between. It's one of these in-betweeners. It's polygenic. It's not a monogenic disease, and you can find it in this scheme in 2 boxes because it can be a mixed pattern disease, relatively close still to autoimmunity, but it can also be an autoinflammatory disease, and both for the child form, the SJA, and the adult form, the AOSD. And this is maybe a little complicated to understand, but from today's perspective, one can say that we not all, but most actually believe in this biphasic model of the disease. It's still an hypothesis. It was introduced by Peter Negrovich from Boston first, but it is there's a lot of data now behind it, really showing that this might be happening in Still's disease. So what happens first is a systemic febrile autoinflammatory disease, maybe triggered by infections, maybe triggered by damage, by tissue stress. Normally a self-limited process, but when it doesn't stop, it turns into autoinflammation. So it simply amplifies itself, and then we have here on the left side the activation of granulocytes, monocytes that secretes interleukins and S100 proteins, and maybe there's a genetic susceptibility in hosts to come to that stage. And then if this doesn't stop, or we don't stop it by medication, then it can shift to a chronic inflammatory arthritic phenotype of the disease, where other mechanisms come into place. And this may be, and you see here in different numbers, research work that is behind it that also we got involved in. You get the induction of Th17 cells by antigen-presenting cells that are hyperactivated by S100 proteins, pro-inflammatory factors, cytokines. You get the activation of CD8 positive autoreactive T cells and the induction from gamma delta T cells that produce IL-17, and they are very pro-arthritic, and maybe all this takes place then, and we have data showing that this also takes place in humans in this later phase. If you look into more descriptive data, you can clearly find that there are 2 phenotypes of the disease. One is more autoinflammatory and febrile and, very highly active in the beginning. This is the systemic form of systemic JA, if you wish. And then we have this polyarticular phase and phenotype later on. And if you look for protein expression analysis, you can clearly distinguish these. So there's a different profile in the patients in the autoinflammatory phase than in the later phase, and many factors, you cannot read it here, but many factors that are from the innate immune system are present in the initial phase, and in the later phase more from the adaptive immune system. And Virginia Pasquale did this gene expression analysis on the lower part of the figure. That is gene expression, the upper is protein expression, the lower is gene expression, and also there you can see a clear difference between the systemic phase and the later arthritic phase of the disease. Then what we believe now is, with having that said, that there's a time that goes by for this shift. You have this acute febrile disease in the beginning, then the arthritis in the end, both in SJA and in AOSD. You have innate immunity primarily in the beginning, adaptive immunity in the end. What does this tell us? That you have, and I will come back to that, a window of opportunity maybe to treat something differently in the beginning than in the end, because different mechanisms mean different therapies are needed, and this is also why certain therapies that are actually good in trials in the first population do not work when you offer it too late at a later stage, if you wish, in the wrong patient or at the wrong time. On the other hand, it is a complex immune dysregulation. So I told you about the shift from the febrile to the arthritic phase with disease progression, but at any stage, basically, macrophage activation syndrome can occur, and this is this is not a contradiction, because macrophage activation syndrome can occur in autoinflammatory disease, but also in autoimmune disease, even in lupus, right? So at any time, you can shift this disease into something that is macrophage activation syndrome, and then other features become very important. I don't have time to go into that, I think, but IL-18, interferon gamma are factors that are extremely important at that point. You need a different therapy at that point. And so that's a third component. So the therapeutics regimen you choose should, in an ideal way, consider all these different factors that are involved. Then another question we already heard in the previous talk on JAA achievements over the past year was this question: is SJA in children different from AOSD in adults? And why is that important? For a number of reasons. One reason is, in AOSD, you have different criteria, Yamaguchi criteria, for example. In AOSD, it is well known that arthritis, frank arthritis, is not required for making the diagnosis. You have an articular involvement, but a real arthritis doesn't need to be present in AOSD to be diagnosed. And they also often consider sore throat and different features that may actually also contribute to the disease in children, but we don't recognize it that much. So I don't want to go too much into detail here because we lose time with it, but to be honest, overall one can say that in SJ and AOSD there are features that have been described differently, but it is clear that a small child is not an adult. I mean, we all know that, of course. We always say so. But on the other hand, most features actually are very much the same. And so we heard it before in the elegant talk on JAA, that we now see it as a Still's disease continuum. So maybe it's not the same disease, but there's a continuum. And most features are similar, the clinical features. The activation of the innate immune system. If you look into mechanisms, the derangement of NK cell functions, you can find in both age groups. There's a predisposition to MAS in both groups. Actually, the lethality of MAS is higher in the adult population. They fear it very much. And there are similar pathways in studies, and the response to anti-IL-1 therapy is also quite similar. So we see this as really a continuum where more or less artificially the EULAR criteria said 16 years of age is the cutoff. Below you can call it JAA. We always had the question, what is between 16 and 18? But there is not really a reason why one should separate these diseases by age. It can occur throughout life. There is an increased frequency of sore throat, as I said, and there is a difference incidence for sure. And there are some features that have described differentially in those. For example, in the adults, there's a sex ratio of 70% female to 30% male, which is not found in children, where we have an equal distribution. So there are differences for sure. But overall, one can say that it really overlaps. And then if you look into registry we do, so if you ask not the evidence, but maybe the experience of what we see, then one has to say, we all say in our studies that the patients fulfill the EULAR criteria. Yes, yes, yes. That would mean 6 weeks of arthritis. But in real terms, many of our patients we have here 207 patients in registry and 35 more in an inception cohort, only about 50 to 60% really had arthritis at the time when the diagnosis was made. So in reality, many patients already with SJA are diagnosed actually without arthritis, but fever and rash are the prominent features, and then the very much elevated acute phase reactants. So, Still's disease, and this is what is now actually agreed upon in 2024, is a disease that is actually quite similar in children and adults, not the same, but similar, and it's a continuum. It is Although it is that similar, there are of course differences. This is a publication not so long ago from 2022. They looked into an Italian collection of patients, a chart review of SJ and AOSD, and you can see that the glucocorticoid use is different in the age groups, and the use of first-line biologics is also different. So obviously the communities, the physicians or the patients are different when you look at the treatment. Also, they have, for those mentioned EULAR press guidelines, and I will come to these guidelines in the next slide, they have not only been the publication of the guidelines. If you are interested in digging deeper, there are also 2 papers in the same version of the Annals of Rheumatic Diseases supporting documents, evidence, supporting the development of the new guidelines. And one very important was this, what some felt revolutionary step to now say we go back from the term SJA to the term Still's disease because we believe it is the same in children and adults. And this is the evidence from different publications and collections. And what you may be able to read, I don't know, but that most factors are similar in both age groups. There's a difference with myalgia, sore throat, and weight loss, where you have a difference, and actually this is more prominent, excuse me, more prominent in adults than in children. The weight loss, actually, for us, weight loss is a very severe sign. To not gain weight is already a problem for children, and so you simply don't pick that up. And the sore throat, I think, is an under-detection because we don't ask our patients, and probably it is also present. So now, having said that, so what should we know about the disease and where do we stand with our knowledge now? This has been transformed in these EULAR press recommendations, where indeed pediatric rheumatologists, adult rheumatologists, patient representatives, HCPs came together to come to this new concept on the diagnosis and the management of the disease. And as I said, there are 2 papers that support with evidence these recommendations. And you have already heard these recommendations, but I want to go one more time deeper into the details of it. So the first really new thing in these recommendations is certainly that there is a new, traditionally old name, because Still's disease is not a new name, but we now would call this disease SJA, and then in parentheses formerly called SJA and AOSD. So this is really new. This is one of the overarching principles. We should call it that, and also the research data, the trials data, can be in that way much more brought together. Then the second overarching principle is what now is considered the top standard of all our therapies, is the treat-to-target approach. So we should come to a shared decision-making with our patients and parents. How aggressively do you want to treat the disease, and what is our common target? What do we really want to achieve? And from a physician's standpoint, the ultimate goal of therapy is drug-free remission. And then the third overarching principle, as we heard, macrophage activation syndrome is a severe complication that at any time we should be ready to detect it and treat it quickly. Then also very important is that in these recommendations there is what is called operational definition. So you recognize it's not classification criteria, and it's not called diagnostic criteria. There are the EULAR classification criteria, there are Yamaguchi classification criteria for AOSD, there had been proposed Printo classification criteria for SJA, and these recommendations come with new criteria that somehow in a way harmonize the already existing criteria. And if you see, fever, of course, is a prerequisite. It has 2 pluses. arthritis is also a criterion, but there's only one plus, and it could be any arthritis. So it doesn't need to exist for 6 weeks, for example. But you can make the diagnosis without, also if there's arthralgia, rash, and then the acute phase reaction. So actually this is new, and arthritis is no longer required, and especially not a chronic arthritis of 6 weeks, and also not of 2 weeks, to be present in these patients. So this is new and facilitates early diagnosis. That's the meaning behind it. Diagnose it early to start treatment. Don't wait. Then there are recommendation statements, and a very important recommendation statements is that you have markers that could support the diagnosis in unclear cases. Because if you do not have arthritis and you have fever of unknown origin with rash and fever, you, as we heard, have to exclude many other diagnoses. That's the recommendation statement 3. But if you want to exclude malignancies, infectious diseases, and all other immune-mediated diseases, you can spend a life of a physician on one patient just to do exclusions. And at some point you want to come to a diagnosis and you want to treat something. And therefore, markers like this, serum interleukin 18 and S100 proteins, calprotectin, you know from stool, but we measure it in serum, are strongly supporting factors, and they should be measured if available. They are not always available, therefore not everyone can measure it, but if available. And you see below data from our group also showing that actually acute phase reactants cannot well differentiate between Still's disease and a severe bacterial infection. Okay, and also other possible diseases, CRP, ESR, leukocyte count, soluble IL-2 receptor, even procalcitonin cannot differentiate clearly between an infection, that would rather argue for an infection if you have procalcitonin elevated, than from SJA. So these markers are not that good. On the contrary, markers like serum calprotectin, here named MRP-814, it's a complex of S100A8 and A9, are very helpful. In the same way, ferritin is a very sensitive marker, but not as specific, and interleukin 18 is also a very good marker. We then went on, and if you want to read it more, you can read in these publications on a commercially available ELISA system that can be implemented in routine laboratory settings. It's the SCAL turbidimetric assay, it's the lower panel, and we measured this in SJA. You see the very high numbers, infections, but also in other systemic inflammatory diseases, in non-systemic JAA, in acute lymphatic leukemia. We heard how important and difficult it sometimes is to differentiate leukemias from arthritis. Here the numbers are low and in the range of the control. So this is a very good marker if available. Then recommendation statements 4 and 5 talk about targets and timing. And this is extremely important, and we already heard about it, therefore I go through it quickly. But the treat to target means, we already heard, the ultimate goal is drug-free remission. But this can mean in 10 years. But what we want to have in Still's disease is a rapid resolution of what's going on. And this does not necessarily mean that you already have drug-free remission, of course. But this is very ambitious, maybe. Already 7 days after you make the diagnosis, there has to be the resolution of fever and a reduction of CRP, C-reactive protein, by at least 50%. At 4 weeks, no fever, you should have normal CRP and a clear reduction of the active joint count if active joints were present before. At month 3, we want to have clinically inactive disease, and you see on the right side what is the definition of clinically inactive disease, with glucocorticoid dosages that are low dose. And at 6 months, we want to have clinically inactive disease without any use of glucocorticoids. And if there is a period of of clinically inactive disease for more than 6 months, we would even call it remission. And so treat to target is relatively simple to understand, but following these principles means a change of the state of the art, because then we are really ambitious, and if we don't meet a target, that means change your therapy. It does mean do something about it, don't wait longer, do more. Increase doses, change medication, install something new. Recommendation statements 6 and 8 then consequently come to what do we do? So what is the treatment? And we already have heard. So we want to use IL-1 and IL-6 inhibitors. And when I say we want to, then I'm part of that group, but many also in the field want to do that. It's idealized, of course. So if we have the capacities, that would be our goal to use that, and as early as possible. What means as early as possible? When the diagnosis is established, instantly. So it's the first line treatment choice. And it also says that maintenance, of course, needs to be achieved without glucocorticoids before we start tapering. Okay, so again, there's evidence behind it. So why IL-1 and IL-6 inhibitors? Because we have randomized controlled trials, and for EULAR recommendations, you need to have a high level of evidence to support a certain type of medication. And here the overall effect model prediction says that IL-1 and IL-6 inhibitors are actually effective and have been proven in RCTs in these diseases to be effective in these situations. And why should it be early and initial? That comes back to the window of opportunity concept I was referring to before. And I showed you this gene expression analysis already from Virginia Pasquale, showing that the autoinflammatory phenotype is different from the later. And what she already did at that point, so she was the first actually in this study to show that giving anakinra to these patients reverts the gene expression profile you see in these patients. So it's effective clinically, but it also shuts off the gene expression that goes on with the activity in this disease. So that was showing that if you do it in this initial phase, you can actually really eradicate the activity pattern that is present at that time. It seems very logical that you cannot do that anymore in the later phase because you do not have a signal, so you will also not see an improvement. And this is basically showing again, and you will see another figure now showing the same concept, but it is so important that I want to bring it to your mind. It's really a take-home message, how we see it, that we have this autoinflammatory phase in the beginning, and we have the polyarthritic form and the SJA with damage. But it's not three phenotypes that come in parallel in different patients. It is in one patient. So a patient goes through this disease in this form, only in some monocyclic forms that are self-limited, maybe it can simply disappear, but otherwise, if we don't shut off in the beginning, we will get this, and we have already seen this biphasic disease course that offers the window of opportunity. And for that, we also have data, we also have evidence. So one point of evidence is to be honest, and this is a limitation, single center experience with a cohort study our Dutch colleagues in Utrecht have been doing, and they are still doing. So they used upfront glucocorticoid-free therapy with anakinra to treat patients with new onset SJA, and they actually had an extremely good response in these patients. There were some patients that needed extra cortisone, so the aim was here to do it even glucocorticoid-free. And most patients actually were able to achieve that. There was a group of patients that needed extra glucocorticoids. There were also some patients that needed a prolonged treatment and were more complicated. But overall, in the long run, a high proportion of these patients that were still under investigation in this long-term observation follow-up were drug-free in the end, so this concept really was very successful. So this is from the recommendations, and I'm sorry if it is a little bit small, baby, but I mean, to go into it, one would need to read the publication, but it is really then, let's say, how you navigate the journey with treatment in these patients. If there is high disease activity, we would give high-dose glucocorticoids plus IL-1 or IL-6 inhibition. If there's not such high disease activity, we would actually start with biologics right away without glucocorticoids or with low-dose glucocorticoids. And then you go through all these interim targets. If there is actually a non-response, you would either increase dose or switch your biologic or switch your treatment and go through it. And if you have clinically inactive disease of glucocorticoids and you have remission, you would start with tapering your treatment and try to get rid of the medication. If there's a flare, then of course you have to go back to treatment or find an alternative treatment. So this all sounds relatively simple, so as if we have found a good solution to manage all these patients. But of course it is still a challenge. There are many, many challenges to this optimal disease management. One is to really early diagnose the patients and recognize complications. One is that international treatment recommendations differ. We now have these EULAR press recommendations, but they somehow would need to be transformed into national guidelines and also maybe policies also by those who finance the medication we want to give. And also activity criteria for the disease are very different and not well established. So we need to find more to diagnose and monitor these patients. And one could say another challenge is, of course, the availability of resources. In the very last, I want to show you briefly, and I may skip a little of that for time reasons, is how we see treat to target in line with what we call a tight biomarker monitoring. And I'm well aware that this may not be possible everywhere, but it should become possible and available in the future. So the primary target of treat to target is, as we heard, remission, clear. But there are intermediate targets. Where biomarkers can help in monitoring patients along this way is actually first in the beginning, because, as I said, sometimes it is not so easy to differentiate the diagnosis in patients with fever of unknown origin. So here we could use biomarkers. Then it would be nice to have predictive biomarkers helping to choose the right therapy. I heard sometimes that cytokine panels have been used to identify, to treat this or that. And finally, it could be very important to decide about changes of therapy in the long run, even if the patients are doing well. So also to confirm, for example, that you have a stable remission. And I want to spend at least 3 or 4 minutes maybe on something we are working on, and this is the S100 pro-inflammatory proteins, and maybe you have heard about it, and many do not really know what is really behind it. So why is this a valid biomarker and could be a very good biomarker for something like Still's disease? So S100 proteins are called S100 because they are soluble in 100% ammonium sulfate. That's for the name. But it's still very irritating because it's a group of proteins of 24 members and they all have different functions and they have a difference in their expression profile. What I am talking about are the phagocyte-specific S100 proteins. So within this family of calcium-binding proteins, there are the calgranulins, phagocyte-specific S100 proteins. There's S100A8 and S100A9, also called MRP8 and 14, to confuse us. And to confuse us even more, the complex is also called calprotectin. And many know it from stool analysis, but it is, of course, primarily not in stool. It is in cells. It is expressed in myeloid cells. And myeloid cells is monocytes, early forms of macrophages, and especially granulocytes. And then there's S100A12, the smaller brother, exclusively or almost exclusively expressed in granulocytes. And what you see here in immunofluorescence microscopy is actually, and not immunochemistry, is S100A12 stained in granulocytes that adhere here to a vessel wall, and there even obviously the cells try to migrate into the tissue, and there the S100A12 is released. Okay, so and then it becomes a pro-inflammatory factor when it is released, an alarmin as we call it today. So it is homeostatic intracellularly for the cells, important for their function, but when it's extracellularly present, it is detected by toll-like receptor 4. So the LPS receptor is then activated by this endogenous alarmin. And that's why it is a damage-associated molecular pattern and can activate the immune system. And colleagues from us have shown for a number of years ago that in active systemic juvenile idiopathic arthritis, these factors can be found in serum at extremely high numbers, much higher than in other inflammatory diseases. And this is true for patients with new onset. You see on the right side, in an active disease, it comes to normal, and in flares, you again see the numbers of these proteins going up. So that's why it is a valid and a good marker to measure in a disease like that. I have been talking about the nonlinear disease activity, and in the very final 2 or 3 minutes, I want to talk about refractory Still's disease, and especially this problem we all have already heard about, the lung disease that may come up with Still's disease. So, of course, refractory disease can be twofold. It can involve systemic features. Often it comes with arthritic features, and when it is arthritic, actually there is not a real good solution for these patients. There is not a single one good medication for them, and that's why we emphasize this window of opportunity, turn off before the arthritic complication occurs. Monitoring, of course, is extremely important to monitor for macrophage activation syndrome, but also for something that has been recognized only in the past, let's say maybe 6 to 7 years, really, to some extent, and this is that lung disease can come with not only recurrent macrophage activation syndrome, but also all of a sudden in these patients. So we recognize that lung disease in SJA coincides with the use of anti-IL-1 and anti-IL-6 treatment. So there was the question, actually is SJA lung disease due to disease processes in recurrent macrophage activation syndrome because the patients are refractory, not responding fully, or is it due to the use of biologics, which would be a catastrophe because this is the medication we promote to use in these patients? And there was, or there is still also a group in the United States promoting this as a DRESS phenomenon, so a drug reaction with eosinophilia. And there are some arguments against this hypothesis. There are also some arguments pro this hypothesis. I don't want to, because this would deserve actually a presentation on its own. I will not go too much into details, but it is a problem coining it DRESS, because then you would say we avoid medication that is useful for these patients. On the other hand, it is of course extremely important to understand what's really going on. And one concept is that actually the IL-1 and IL-6 inhibiting biologics somehow shift the phenotype of alveolar macrophages, and together with GM-CSF they would normally be scavenging and recycling surfactant, and they cannot do it that much anymore, and this surfactant disbalance leads to alveolar proteinosis, and this then triggers the recruitment of Th1 cells, and in the long run, a Th1 and interferon gamma-driven pro-inflammatory inflammatory lung disease. And there are data actually showing towards that. Actually, Scott Ganner's group in Philadelphia has been working on that and has been showing that in macrophage activation syndrome and in SJA, you have overlapping features of components that are overexpressed in serum profiling. But in the ILD spectrum, especially IL-18, obviously seems to be in the patients with lung disease and macrophage activation syndrome having similarities, and therefore we are waiting for drugs at the moment targeting IL-18 specifically or as a bispecific treatment together with other cytokines. I skip this and come to the summary. So I wanted to tell you what is new what is the state of the art from my perspective in 2024, what is the greatest excitement. I think there's really a good excitement about these new guidelines. I'm clearly biased, I have to admit, of course, what shall I say, but I find this indeed quite spectacular that we agreed upon a common, let's say, nomenclature and calling this Still's disease again, emphasizing the parallel features. It's a biphasic disease, that is very important. Bridging autoinflammation and autoimmunity. There's the treat to target concept in systemic JAA, aims for disease remission, and with the biphasic disease model there comes the window of opportunity. So in the initial phase you have a certain window opened up where you can use a specific treatment that can really put out the fire in these patients. Tight monitoring with mechanistic biomarkers is important. I have told you S100 proteins, IL-18, these are mechanistic biomarkers better than acute phase reactants. If there comes MAS, interferon gamma, CXCL9, CXCL10 are important. And you always have to think of these disease complications. Macrophage activation syndrome at any time. In the long run, if you have the joint destruction, it's almost too late. It's always the most burdening patients, and we have no good clues for the lung disease. We also have no clue at the moment, but we have to take that seriously. And I want to show you a little bit where I come from. It's very different from India, I have to say. It looks like this. So this is in the upper part, you see our city hall and houses as they look in Munster, where I come from. And you can see here down there, this is what Munster looks like, also very different from India. You can see that it's a very Catholic city. In the middle there's the cathedral, and the people were then gathering around, and there has been a wall around it, and this is where then the city spread out. Our hospital looks like that. It is constantly under construction, as your hospitals certainly also are. And this is our team down there. To the left, blue in the blue sweater, that's Klaas Hinze, and the second to the right is Helmut Witkowski, my colleagues. And with that, I want to thank you very much for first having me here, for listening to me. I'm happy to take questions.
Thank you, sir. We are fortunate to have you here with us.
So this is a thing, Odisha tradition. I also like to request our co-organizing chairperson, Dr. Mamta Devi Mante ma'am, to also come on the stage, please. and Dr. Ashutosh sir, IAP Bhubaneswar City branch, Dr. Seba sir, EB Central EB branch, Dr. Mrityunjay sir, booking. Ma'am will, Priyankar sir and ma'am will present the scroll. Vijay sir, you have the scroll. And I request Dr. Vijay sir and Vignesh sir to present the scroll. So, the Paediatric Rheumatology Society presents this token of appreciation to Professor Dr. Dirk Foel, who heads the Department of Paediatric Rheumatology and Immunology at University Children's Hospital Munster, Germany, and member of the European Network of Rare Diseases, and also a member of the EULAR Center of Excellence of Rheumatology Research. Thank you. We'll have a group photo.